Dr. Koh is the Harvey Feinberg Professor of the Practice of Public Health Leadership at Harvard School of Public Health and at the Harvard Kennedy School of Government. Dr. Koh was appointed the Under-Secretary of Health at the U.S. Department of Health and Human Services between 2009 and 2014. So he has a very wide experience in clinical, academic, and government roles. We share with Dr. Koh, and we learned this morning that we share an extraordinary mentor in Dr. Wong-Ki Hong, who recently retired as the chair of the Division of Cancer Medicine at MD Anderson Cancer Center. So I think we have common sources for our knowledge, and we look forward to his presentation that will be in the area of policy dimensions of spiritual care in the United States.
Thank you. Thank you very much, Mr. Chairman, and it's indeed a great honor to speak before this inspired global audience on these truly sacred topics in this holy setting. It's my great pleasure to speak on the topic of policy considerations for spiritual care in the United States, and I'll be giving this presentation from multiple perspectives. As a physician who has trained in multiple fields, including cancer, as a clinician who has cared for patients for over 30 years, as a professor of public health at Harvard, and perhaps most importantly of all, as one who has held major policy positions in health in the United States. First as Commissioner of Public Health in Massachusetts from 1997 to 2003, and then, as the chairman has noted, most recently as Assistant Secretary for Health in the U.S. Department of Health and Human Services under President Obama. And through my travels in these various roles, issues of meaning and purpose and spirituality have guided me from the beginning, both professionally and personally. So, for example, when I think of issues of meaning, purpose, and spirituality, I often think of my friend and mentor, the late Reverend William Sloane Coffin, who was the chaplain at Yale University when I was a student there. Reverend Coffin used to remind us that we cannot view a patient as an uninteresting appendage to an interesting disease. He also said that the primary religious and spiritual emotion is gratitude. So in that spirit, I want to say that I'm very grateful to all of you. I'm grateful to the organizing committee, with special thanks to my dear friend, Dr. Christina Puhalski, whose name will be mentioned multiple times in this presentation. I'm very grateful to my wife, Dr. Claudia Arag, and my son, Stephen Koh, who have joined me in this very special trip to Rome. So for this presentation, I'll be sharing some insights on health and spirituality and spiritual care, making some observations about how those themes apply to hospice and palliative care in the United States from a policy point of view, and then make some concluding observations about how this can extend in broader contexts in the health system of the United States, first in Veterans Affairs, the VA, and then ultimately beyond. So it was in 350 BC that Aristotle first said, the soul is the full actualization of a person, incorporating the body, the purpose, and ultimately the sum of total operations of being human. And then I was so glad that my colleague from the WHO reminded us of this truly inspiring definition of health that I repeat in just about every speech, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I love that definition. I love it so much I'm going to say it again. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This means that if we truly care about health, we need to pay attention not just to the health of the body, physical health, but also of the mind, mental health, and also health of the soul, social and spiritual well-being. And then, of course, the other very inspiring quote from the WHO in 1946, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. I love that phrase, the highest attainable standard of health. That means that our good health is a gift, and it's precious, and it's fragile, and it needs to be cherished, and it needs to be protected, and that's what public health is all about. In the United States, our country of 330 million or so, we are having vigorous conversations about the future of health for multiple reasons. First, we have the most expensive healthcare system in the world without the health outcomes to match. Our health system is highly fragmented. It has a traditional payment model called fee-for-service. That means if a doctor or a hospital provides a service, they get paid. If they do more services, they get paid more, regardless of whether it ultimately helps the patient or not, regardless of whether it's efficient or equitable or is something that the patient even wants or not. It's specialty-driven. Our insurance coverage is a patchwork. It's a mix of private employers that covers about 160 million people in our country, a Medicare, an insurance program for those 65 and older and disabled. That's about 55 million people in our country, or Medicaid, which covers over 70 million. That's insurance coverage for low-income or disabled people. Sometimes there's confusion about whether a person should be covered by Medicare or Medicaid and is eligible for both, what we call dual eligibles. And you put this all together, it's very fragmented. There's little coordination, high costs, and tremendous frustration. So it was a great source of great privilege for me to be Assistant Secretary at the Department of Health and Human Services when in March 2010, President Obama signed the Patient Protection and Affordable Care Act into law. We can say a lot about what the Affordable Care Act has accomplished and not accomplished in the 8 years since. We know that 20 million more Americans have achieved health insurance coverage than before this act was signed. There's tremendous controversy about where we should go with this act and how we should cover more people at lower cost and at high quality. But regardless of who you are in these controversies, there is universal consensus that the goals for the future for our country is more patient and person-centered care, care that emphasizes quality in the system and quality for the patient, that's coordinated and team-based. Everyone is looking to move beyond the traditional fee-for-service payment model into so-called alternative payment models that stress value over volume. And through all of this, we want to honor patient preference in the medical decision-making process, which sometimes is honored currently, but oftentimes is not. So in the midst of this, we can talk about issues of spirituality and spiritual care. You heard this morning from Dr. Puhalski that there was a very important consensus conference defining spirituality as a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence. We can talk about dimensions of spiritual distress, needs, and struggles. Many speakers here have talked about some of those dimensions. Here's a checklist offered by Busing that said that some of those dimensions involve social, emotional, existential, and even religious dimensions. When I returned to Harvard as a professor some 3 years ago, after being in Washington, I had the great privilege of joining some colleagues in a relatively new Harvard initiative on health, religion, and spirituality. The three leaders of this initiative that I want to mention today. The first is Dr. Michael Balboni, who's pictured here. He just recently co-authored this book called Spirituality and Religion Within the Culture of Medicine. And then the other two leaders of this initiative, Drs. Tyler Vanderweel and Drs. Tracy Balboni and I, had the tremendous honor of writing this little viewpoint in the Journal of the American Medical Association, JAMA, that was published last summer, entitled Health and Spirituality. You see this entitled in the lower right. And in this, we review some of the challenges and opportunities regarding spiritual health in the U.S. And we have a highly diverse country with respect to race and ethnicity. Having said that, some 77% indicate a religious affiliation, about 46% Protestant, about 20% Catholic. Many patients, sometimes almost all patients, regardless, depending on the study you read, call spirituality important in their lives. About a third attend religious services weekly, but most receive minimal or no spiritual support from medical teams. This lack of spiritual care is a prominent source of patient dissatisfaction in hospitals. Spiritual distress is common, and these issues don't affect just patients, they affect providers too. We know that chaplains provide very important spiritual care services, but they cannot bill separately or be reimbursed. Medical providers say they don't have the time training to provide such spiritual care. And then right now in the medical literature in the United States, there's tremendous attention to physician burnout. And we suspect that spiritual health issues are driving a lot of this, with about half of US physicians reporting exhaustion and burnout and questioning the meaning and purpose of a lot of their daily work. So these are broad issues that affect patients and healthcare providers alike. So let's start from a very broad epidemiologic viewpoint, because if you look at these first two studies referenced here, it just shows the potential of addressing these issues and improving ultimate health outcomes. The first study has to do with religious service attendance, and this is in the Harvard Nurses Health Study led by my colleague Dr. Tyler Vanderweel, who is noted here, a study of some 75,000 participants. And Dr. Vanderweel and colleague noted that people, nurses in this particular case, who reported regular religious service attendance had up to a third reduction in all-cause mortality. And other studies have shown reductions in risk in depression and in suicide. So we could have a long debate about whether that's association or causation, but this link is very strong. Lots of discussion about what's causing this at least strong association or correlation between regular service attendance and improved health outcomes. Is it because religious service attendance involves community? Is it because it involves direct provision of care from spiritual leaders? Is it because there are healthy norms being practiced, like tobacco-free environments? There's much more research that needs to be done. The second study is a meta-analysis of 10 prospective studies of about 136,000 participants, showing that possessing a higher sense of purpose in life is associated with a reduced risk for all-cause mortality and cardiovascular events. So this is a very striking association as well. We know that when we integrate spiritual care into healthcare, it enhances satisfaction of patients at hospitals. So now there's some early work to see if there are specific interventions that can try to explain some of these broad correlations that I note here. There was a review in PLOS One in 2017, a systematic review of religious and spiritual interventions that showed small benefits, but of course suggested that more research was needed. So we're looking to try to identify specific interventions, given all the caveats that my colleagues have mentioned about how hard that is to do. So right now we're trying to build the evidence base for spiritual care, asking some basic questions. What is it? How do we deliver it? Who will deliver it? For whom and when? Some of those questions are addressed by Dr. Harold Koenig in this book that you see on the right, Spirituality in Patient Care. And there have been expert groups who have convened and offered some models for spiritual screening and spiritual history taking, which can be very brief and potentially offered by any clinical provider, backed up by a more in-depth spiritual assessment that could be extensive and could be conducted by board-certified spiritual care professionals. So in this model, and Dr. Puhalski referred to it this morning, we could have, for example, physicians and chaplains working together to implement various aspects of this inquiry. And this summary of the state of the science was reported in this publication below, led by my colleague, Dr. Tracy Balboni. And I know that Chaplain George Hanso is in the audience, is also a co-author on this paper. So also discussions about exactly how to begin to assess this information from patients to do spiritual screening and history taking. How do we even broach the topic and allow this conversation to go forward? Here are some suggestions. So on the top left is a publication that involves colleagues that include Dr. Susan Block from Harvard, a colleague of mine. Communication regarding serious illness should address some 8 domains with questions like, what are your biggest fears and worries about the future with your health? On the right, a little summary of the FICA tool that Dr. Puhalski has led globally, asking about faith and belief, importance, community, and addressing this in care with a sample question such as, how would you like me, your provider, to address your spirituality in your health care? And then on the lower left, another publication referring to the impact potentially of asking one simple question to probe spiritual concerns at the end of life: are you at peace? So we can debate about which one of these to offer when, but at least we use these tools to begin the conversation and elicit key information about spiritual health and spiritual distress. So how do some of these themes apply to hospice, palliative care, and then more broadly in the U.S. health system? Let's start with hospice and palliative care. One slide on hospice. You've heard a lot about hospice in this conference already, and the pioneering role of Dame Cicely Saunders. In the United States, the first hospice was opened up in Connecticut in 1974 by Dean Florence Wald of Yale, and she is pictured here. But I mentioned these themes have great personal connection with me, and on the right I also want to honor Reverend Edward Doblehall, who was a family friend of ours when we were growing up in Connecticut, and he was the chaplain at Yale New Haven Hospital. And I remember fondly as a young boy hearing him speak about how inspired and honored he was to help found the first hospice in Connecticut along with Dean Wald and others. So I picture Reverend Doblehall and honor his legacy here. We can now say there are about 4,000 hospices in the United States. In terms of policy, in 1982, a Medicare hospice benefit was introduced. And in 1983, an accreditation process by the Joint Commission, which accredits healthcare institutions in the United States, was begun. And below you can see a little more details about the Medicare hospice benefit. As noted by our rabbi colleague this morning, this is specifically restricted to people with less than 6 months to live. It covers the cost of non-curative care for terminal illnesses. This care is usually provided at home. The good news is that hospice has been shown to lower hospitalization rates, ICU admissions, invasive procedures, and total costs. There's a reference in the lower right by David Cutler and others from Harvard about these outcomes. But this benefit covers all services to people at the end of life and does not necessarily single out spiritual care or necessarily specifically reimburse spiritual care. So here is a venue where perhaps more can be done. And then palliative care in the United States, we've heard already how the WHO statement has been very important in advancing palliative care in our country. I did want to refer to this 2015 landmark report by the Institute of Medicine, the IOM, now called the National Academy of Medicine, called Dying in America. And this IOM report states that of the 8 core components of end-of-life care, which you see below, one of them, or rather 2 of them, refer to frequent assessment of patients' physical, emotional, social, and spiritual well-being and attention to patients' spiritual and religious needs. So this report is absolutely the go-to document in the United States in terms of the current status and the future of palliative care in our country, and spiritual distress and spiritual needs is explicitly mentioned there, but perhaps not enough. One positive outcome of this report was that Medicare, in 2016, as you can see in the middle of the slide, agreed to start paying physicians to have advanced care planning conversations and discussions. So billing codes were set up for advanced care planning. It reimburses perhaps not enough money for physicians who are committed to starting this conversation and coordinating such care. A recent study just came out saying that only 1 in 3 Americans completes such advanced directives for end-of-life care right now in our country, so that's way too low. But at least there's been some policy advancement about reimbursing physicians to start this process and realize the potential of the Patient Self-Determination Act, which was passed in 1990. Back to this Dying in America report by the IOM in 2015, they concluded with 5 key recommendations for palliative care. So I list them here. Insurance coverage of comprehensive care for individuals nearing end of life, develop quality standards for clinical patient communication and advanced care planning, create professional education certification and or licensure, and that's not just physicians and nurses, but also chaplains and social workers and others, improve payment systems and policies, and expand public engagement in education. I have bolded where they specifically mentioned spiritual needs and spiritual care, and it's specifically explicitly mentioned only in the first recommendation, so you see that on the top. It's implied throughout the others, and perhaps we should be doing more about that in the future. Let's move on to the Veterans Administration, which is the largest integrated health system in the United States, with 170 medical centers and over 1,000 outpatient sites taking care of some 9 million enrolled military veterans. This is a system that has explicit policy and procedures ensuring availability of spiritual and pastoral care for all patients. On the bottom, you can see a great rise in the delivery of such care within the VA system. They benefit from the implementation of a national bereaved family survey. You can see some results here. The 90% of veterans' families want spiritual support, and 70% or so always or usually receive that kind of spiritual support, so that is very impressive. So we have some data here to show that provision of such support by chaplains and others is starting to address the need. This is information from Dr. Joe Francis of the VA. And the VA is starting to do more in this area as they address key issues like suicide. For example, in some years, such as 2012 and 2013, suicide deaths are more common than combat-related deaths among military personnel, and there have been attention for spiritual care of veterans to, of course, make this tragic outcome less common. And then some last minute on how this could be advanced in the broader health system. As I mentioned at the outset, addressing spirituality as part of national attention to physician burnout could be another way of getting more broad attention to this topic. This first article is one that just came out in the New England Journal of Medicine last month, Beyond Burnout, Redesigning Care to Restore Meaning and Sanity for Physicians. And I put this quote on top from one physician: "At the highest level, we are disconnected from our purpose and have lost touch with the things that give joy and meaning to our work," unquote. It'd be fascinating to have U.S. physicians to talk about spirituality more explicitly and see how that relates to the burnout crisis. So more discussion on that. In the last slide or two, I mentioned that in February, just a couple of weeks ago, the President signed the Bipartisan Budget Act into the law, which now enables certain provisions of the so-called Chronic Care Act of 2017 to move forward. This is an alternative payment model to provide more Medicare benefit coverage for care delivered at home. This could include interdisciplinary care from teams that may include a chaplain, minister, or other clergy. Some groups in our country would like that word "may" to be changed to "shall," but the good news here is that there's some respect and attention to the importance of interdisciplinary care teams in a context like this. And then, as I mentioned, we have tremendous discussion about alternative care models, alternative payment models for the future. Many in the U.S. are familiar with the so-called accountable care organizations, groups of doctors and hospitals and other providers providing coordinated high-quality care to Medicare patients. There's also a model called accountable health communities that try to share responsibilities and coordinate responsibility throughout entire communities and measure health outcomes. This is where I believe faith-based organizations can be tremendous leaders, joining with medical groups. When I was in the Obama administration, it was a great honor for me to work with the U.S. Federal Offices of Faith-Based Partnerships, which was established in 2001 by President George W. Bush and then extended through the Obama administration. So this is, again, an explicit way of joining religious and spiritual leaders with health leaders to promote cooperation and collaboration about health issues. So I look to this office, hopefully, to continue that conversation and move that collaboration. And so as I end, what is the vision and what could be next steps for the future of spiritual care? When we ask what, it should be patient-centered communication and care to identify spiritual needs and distress, create quality in the system and value that we all want. How? A generalist and specialist model that's team-based and coordinated. Who? Both medical and spiritual care providers can offer such care. They should be certified, licensed, and reimbursed to do so. We should partner with religious communities. For whom? Not just patients, but for providers too, with tremendous attention to this physician burnout issue. When, I would like to propose, not just at the end of life, which is critically important, but throughout life, if Aristotle is right, and these issues are critically important to what health is all about. So we need dialogue and funding for this research. So on my final slide, I go back to where I begin, that I am very grateful to the organizers, to the Academy, to all of you. That is the primary religious and spiritual emotion. Reverend Coffin also used to say that spirituality means living the ordinary life extraordinarily well. I love that definition. And he also liked to say, the glory of God is a human being fully alive. And I think that's what this conference is all about. Many thanks again to my colleagues at Harvard, to Dr. Puhalski, to my wife, and to my son for being here, and thanks to all of you.